Alright, today we'll be talking about PVNS or Pigmented Villi Synovitis. It is a locally aggressive neoplastic disease of the synovium or tendon sheath. It can be found in the joint or tendon sheath. If it's found in the tendon sheath, sometimes it is called the giant cell tumor of the tendon sheath. The incidence is quite rare. It's reported about 9.2 million per year in the United States. Demographically, it is most commonly in the mid-adult age, about 30 to 40 years old, but can also be occurred at any age. It is equally occurred in men and women. Anatomic location most commonly seen in the knee, but may occur locally within the joint or diffusely. So the localized or the intra-articular or the classic form is at the anterior part of the knee, and it is the most common site of the involvement, about 80%. The most commonly affects the patellofemoral compartment at the intra-patellar fat pad. So it can also happen at the hip, ankle, shoulder, and also elbow. It can also be diffuse or extra-articular extension, and it behaves quite differently from the localized. Etiology, so it is caused by an overexpression of CSF1 gene. This overexpression leads to the clusters of aberrant cells creating local areas of soft tissue hypoplasia in the synovial cells lining those joints. The locally aggressive neoplastic synovial disease is not really a true neoplasm. It's actually a benign case. It also correlates with genetics. The mutations of the chromosome 1p13 in majority of the cases. Associated conditions, like I said just now, is the giant cell tumor of tendon sheath, also known as pigmented villonodular tumor of the tendon sheath. There is a classification of the localized versus diffuse PVNS. So for the localized PVNS, most happen in the knee, hip, and ankle, but the diffuse PVNS mostly at the knee. Age for the localized is about 30 to 50 years old, but diffuse PVNS is less than 40 years old. Gender-wise, both for localized and diffuse are about equal, male and female. The prevalence is also almost the same. Presentation for the localized PVNS is painless, swollen joint, and is usually long-standing. But for the diffuse PVNS, is painful, swollen, tender, and usually cause very limited mobility. Radiographically, you can see from the X-ray, the localized PVNS, there's osseous erosion from localized pressure. And for the diffuse PVNS, it's degenerative changes on both sides of the joint. For MRI, for localized PVNS is well circumscribed soft tissue mass. However, in diffuse, it will appear as ill-defined or poorly circumscribed soft tissue mass. So, the recurrence of diffuse and localized PVNS. For localized PVNS, after treatment is usually recurrence rates is about 8%, but after the treatment of diffuse PVNS, the recurrence is about 30%. Usually, the presentation of this PVNS, the most commonly patient will come with pain and sometimes swelling of the knee. It will, from inspection, you see some joint infusion and erythema. Palpation is tenderness along the joint lines. Motion, sometimes if patient comes at a very acute stage, it will be very limited motion of the affected joints. The most recommended views, radiographically, AP and affected joints. Findings from the ultrasounds can also show soft tissue swelling, may show some cystic erosion with sclerotic margins of both sides of the joint. studies for labs, blood investigation, you can scan for CRP and ESR, which often quite show normal sign despite CRP and ESR would be high in the localized PVNS. Diagnostic arthroscopy or arthrocentesis is indicated for recurrent hemorrhagosis. Findings would be grossly bloody effusions. But for the diagnostic arthroscopy is the gold standard for diagnosis. And usually the biopsy would be performed and sent to the lab. Findings from the diagnostic arthroscopy would be brownish or reddish inflamed synovium, which is very typical of PVNS. And it's also described as the frond-like patterns of papillary projections. So if we were to send those samples for biopsy, the gross histology would show a proliferative mass extending from the synovium, mononuclear stromal cells infiltrating the synovium, and highly vascular villi lined with plumb hypoplastic synovial cells. So what are the differential diagnoses for PVNS? It could be synovial chondromatosis. So synovial chondromatosis, if you were to if you were to view it in X-ray, it will be more calcifications. Hence, it will look more whitish on the X-ray. Hemophilia or hemarthrosis, rheumatoid arthritis, septic joints, or also other neoplasia. Treatment-wise, it could be observation, just we see the indication, and if let's say the symptoms improve. So usually we don't really do anything much, but most of the case we will opt for operative. Operative is partial synovectomy, most for the local form of the PVNS, and also we could do total synovectomy or plus minus external beam radiation. Usually we will do total synovectomy, and if the patient recur, then we will proceed with radiation. This total synovectomy usually is we would opt for patients who are very grossly symptomatic and painful disease. Complications of the PVNS, of course, it could recur, and also it could cause joint destruction if it's left untreated, moderate to joint severe deformity. If this is further left untreated, it could lead to joint damage and also distal limbs damage, which later on can lead to amputation. Prognosis for PVNS is high rate of recurrence and accelerated degenerative changes of the knee, will ultimately requiring arthroplasty. This, of course, if it's left untreated. Total knee replacement in patients with PVNS is associated with the high complication rates. That's all for PVNS.